All right, well, thank you all for coming in today to come and see this presentation. So my name is Dakota. I'm a PGY1 pharmacy resident here at St. John's Hospital, and I was mentored in this project by Tiffany, who is not here currently.
We don't Tiffany.
Yeah. She's on her way. Before we get started, I do have to just give my disclosures out. I don't have any financial or any potential conflicts of interest with any of the information presented in this article, in this presentation. And I am going to be discussing some off-label uses for medications as we go through. These are the objectives for the presentation. I'm not going to read them off to you. They're in the handouts on the slide. And then this is just a little slide that has the different abbreviations that I've used. So if I ever say an abbreviation or if there's one on the handout that you're not sure what it is, please refer back to this slide, or you can always just clarify with me as well. And so for today, we're going to be going over some information about the SGLT-2 inhibitors overall, talking a little bit more about their mechanism of action, how they're dosed, etc. We'll do a brief review of the standard of care medications for our heart failure drugs. And then we'll take a dive into the primary literature that kind of asks this question about the utility of SGLT-2 inhibitors in heart failure patients. And then we'll kind of determine where the place of therapy is for these SGLT-2 inhibitors. And so the way that our SGLT-2 inhibitors work is in the nephrons of the kidneys, and it works specifically in the proximal convoluted tubule of the kidneys. And so if we blow this up, where it acts is on the SGLT-2 transporter. That's the sodium glucose link transporter. And what that transporter does is it takes sodium and glucose from the lumen of the nephrons and then reabsorbs it back into the blood. And so our SGLT-2 inhibitors stop this from happening. And so what that ends up doing is it causes our body to excrete a lot of glucose and a lot of salt. And in doing this, it also draws water into the lumen of the nephrons as well. So it causes a diuretic effect. And downstream, this has the effects of lowering people's blood pressure, lowering glomerular pressure, stops albuminuria, proteinuria. It's been shown to help patients lose weight, and it helps to lower uric acid as well. And so right now, where our SGLT-2 inhibitors really fall in therapy is to be used as an agent to reduce glucose and A1C in our patients who have type 2 diabetes. This isn't for our patients who have type 1 diabetes. Those patients are insulin dependent. They need to use injectable insulin. But for our type 2 diabetes patients, this is one of the agents that we can use. It's one of the second oral agents that we'd add on, the first being metformin, that's recommended by the American Diabetes Association. And then SGLT-2 inhibitors are an add-on therapy to metformin and lifestyle modifications. Interestingly, in the 2019 update to the ADA guidelines on diabetes, they actually do give a shout out to SGLT-2 inhibitors and our GLP-1 medications, which are recommended to be used in patients who have ASCVD risk factors or have established ASCVD. Specifically, they make the recommendation for SGLT-2 inhibitors to be used when heart failure is a big concern for our patients. And so we'll be talking a little bit later about where that recommendation comes from. And we've already talked a little bit about the benefits. And so here's just a little table about the dosing of the different SGLT-2 inhibitors. And this is something that's in the handouts just for your guys' reference. What I do want to point out is that these medications do have cutoffs for when they can be used and when they should not be used for patients who have impaired kidney function. So in our patient, you'll see that it's completely contraindicated class-wide in our patients who have an estimated glomerular filtration rate of 30 or less. And it's not really well studied in these patients who have some mild impairment, less than 60 or less than 45, depending on which agent you're looking at. So that's an important thing to keep in mind with these medications.
Can I interrupt you?
Yes, of course.
Have you found that any of these, because cost is going to be a big issue, are any better covered than another one?
As far as insurance goes, that's not something that I'm aware of.
Okay.
One being covered more preferentially than the others.
Okay.
One thing that is interesting is that empagliflozin does have some more substantial data at a glance that may drive insurance companies to cover empagliflozin more, but that's speculation on my part. It's not something that
Okay.
I'm aware of. If insurance companies cover one over the other preferentially, it's going to vary depending on which company you look at.
Okay.
Another nice thing about these drugs is that they don't have any drug-drug interactions. They're all once daily dosed medications. And the other important point about these is that they're not very well studied in patients who have hepatic impairment as well. So getting into the warnings that go along with these medications have been associated with euglycemic ketoacidosis, so basically diabetic ketoacidosis, which is a medical emergency, but the patient does not have hyperglycemia. And this is something that the FDA has put out a safety alert about, just because it's something that if a patient has a history of this, you wouldn't want to start SGLT-2 inhibitors, and you'd want them to be monitoring their lab values routinely because this can occur. Another big warning that's been associated with these guys is Fournier's gangrene and genitourinary infections, UTIs. And this, if you think about it, this makes sense with the mechanism of action. You're dumping a whole ton of sugar, glucose into the urine, and our bacteria, funguses, all like glucose. So when that happens, you're putting them at greater risk for UTIs, so you might want to avoid this drug in populations who are at risk, so such as truck drivers are kind of notorious for getting Fournier's gangrene. So just depending on like the patient's occupation or even their just past medical history, if they have a history of very frequent UTIs, it'd be another reason to kind of shy away from these medications. The other two big ones are hypotension and bone fractures. So in our patients who have osteoporosis or our patients who have kind of a labile blood pressure, this would be a reason to be very careful about adding these medications on, just because you don't want to put them either more at risk for having bone fractures or bottom out their blood pressure and cause them to have fainting or syncope, or not to be perfusing their organs very well because we're dropping their blood pressure so low. The other ones on there are a little bit less concerning. The hypoglycemia, it is more likely in combination with insulin or other insulin secretagogues in theory. This isn't something that's been demonstrated a lot though, and the nice thing about SGLT-2 inhibitors is that they're not a insulin-dependent medication in that they don't affect how much insulin is put into the body, and they don't affect like how long it sticks around. It's more dependent on the glucose being present for it to actually get rid of. So the hypoglycemia is less of a concern, but it's still something that's possible. And the elevation in LDL is something else that's been seen, not a huge deal. The bladder cancer and empagliflozin is something that's controversial. It's been shown in some studies, and it's been shown to actually have benefits in other studies. So that's something that we're not very sure on, but in something that has active bladder cancer, it'd be something to probably avoid. Okay, now we're going to do a quick review of our standard of care medications just to kind of set the stage for where our SGLT-2 inhibitors fits into all of our heart failure medications. And before I go diving into these, I want to go over a quick few principles about titrating drugs in heart failure patients. The nice thing is that this actually works out to an acronym of SGLT2. And so that the tidbits I have for that is to start low. So we're going to start all of our medications at a low dose, a low initial dose relative to where we're trying to get to, which is the target dose. And so we'll slowly titrate that either over doubling the dose after every about 2 weeks is about a good kind of rate to be adjusting medications. And then with those adjustments or with any initiations of new drugs, we'd be wanting to monitor lab values wherever they're appropriate. So that's getting your vitals, getting your BMPs. With drugs like spironolactone, it's recommended to get those as soon as 72 hours after, or at least within 2 weeks is a good idea with most medications to have some sort of follow-up on how that's impacting their physiology. And then, like I mentioned earlier, we're going to be titrating to a target dose or to a maximally tolerated dose. And the reason why these target doses are so important, and I'll go over those a little bit later, is because we see the greatest benefits both in hospitalizations and mortality at those doses. So the reason why we try and get to that target is just so that we get the biggest impact on our patients in preventing them from having cardiac events and having mortality. And then the things that's going to affect whether or not we are able to titrate is going to be our patient's blood pressure, our patient's lab value, their kidney function, etc. And so if we can't make it to the target dose, then we're going to try and make it as close as we can to that dose. So the highest tolerable dose that the patient is able to take. Okay, and so a drug class that you're probably all familiar with is the ACE inhibitors and ARBs. So these are one of our first-line agents in heart failure. They have a substantial mortality benefit when they're used in our patients with heart failure. They prevent cardiac remodeling, prevent hospitalizations with heart failure. And they're also indicated for reduction in blood pressure in any patient who has heart failure. And so on the right, I have just where the initial doses are for our different ACE inhibitors and ARBs and target doses for each one, just for your reference there in the slides. And the important things to monitor with these guys are going to be, one, our vitals, so watching our blood pressure especially, because these are agents that will drop blood pressure, and watching our BNP, because these agents do have renal adjustments, and we do have to watch kidney function with these medications, and they're also going to affect the patient's potassium. In this case, it's beneficial in most cases because it's going to cause them to retain potassium. It will increase their serum potassium levels, which can be nice in our heart failure patients where we might be using diuretics all the time and causing them to waste their electrolytes. This drug can help them to kind of hold on to that potassium. But it's something important to watch because we can always overcorrect potassium as well and end up too high. Some important counseling points with these guys is just warning patients about the dry cough with ACE inhibitors. That's not present with ARBs, and that's just due to each class's mechanism of action. If a patient does develop a dry cough with ACE inhibitors, it's an okay reason to go ahead and switch over to an ARB, where the dry cough isn't really associated with their use. The big counseling point that's associated with both classes, however, is angioedema, which is how I explain it to patients when I go and counsel them, is just telling them it's very similar to an allergic reaction. And the reason that we're worried about it is that it can cause swelling in the face and in the throat, and that can close their airway. And so if they ever have any kind of tingling in the face or in the throat, any kind of like itching, anything that feels like an allergic reaction, it's a good reason to get into the doctor right away.
Question for you.
Yeah.
It says on there the target dose of losartan is 150. Is that true?
Let's see. 150.
We were talking about in hypertension, it'll usually say just to 100, and we didn't realize.
I thought the max
We thought max dose was 100, but so it's a higher for
Yes, I believe that's correct. I'll double check on that for you, but that 150 for losartan should be correct. Okay. Our next class is another one that I'm sure you're all very familiar with, are the beta blockers, and these are another first-line agent for any patient who has heart failure with reduced ejection fraction and is symptomatic. And this is another drug that's going to prevent remodeling of the heart tissue. It's going to help. It'll have that mortality benefit at the target dose. It'll have the benefit for hospitalizations, and it's also another agent that's indicated for blood pressure and heart rate reduction in any patient who has heart failure. We have a lot of different beta blockers that we can pick from, but we prefer to use the beta-1 selective beta blockers. And I have a list of those in the table on the right again. And again, we're going to be trying to get to that target dose. This is another agent class that does have target doses that we'll be trying to attain. These drugs primarily are going to be impacting our heart rate and blood pressure. They don't have so many laboratory parameters that we're going to have to be watching out for. And a nice tidbit to know about these different beta blockers that are selective for beta-1 is that carvedilol is going to have the biggest impact on our blood pressure because it does have some action on our alpha-1 adrenergic receptors as well. It kind of does double duty for us. So if blood pressure control is something that we're struggling to achieve in patients, carvedilol might be a good agent to use. Versus if we have a patient who we have them on a lot of different medications that are lowering their blood pressure and we're trying to kind of keep their blood pressure from dipping too low, then metoprolol might be the way that we swing on that. Some important things to tell patients about with these medications are just that they're probably going to feel pretty tired and crappy after initiating these or going up on their dose, and that's just part of their body adjusting to the medication. It's going to stop their heart from being quite so excitable, and so it is going to make them feel pretty tired starting off. Specifically for our diabetic patients, so this is especially important for our patients where we might be considering SGLT-2 inhibitors, is that our beta blockers mask our symptoms of hypoglycemia. So this is an important counseling point for any patient who has diabetes who is getting started on a beta blocker, is that they might not have some of the classic signs of hypoglycemia that they were told they would before, so like things like tremors would be masked by beta blockers. There is one symptom that does still present even with beta blocker use, which is breaking out into a cold sweat. So that's the symptom that I would counsel patients to be watching out for, if to recognize that they're having hypoglycemia, to prompt them to check their blood sugar. But that's a very important thing to let patients know. Okay.
So a question, if
Yes.
somebody is on, let's say I have a patient who's got heart failure, he's on propranolol
Mhm.
for tremors. Can I switch him to carvedilol or metoprolol? Will that work for their tremors as well? So that it works better for their heart failure?
So propranolol can still be used for heart failure. We prefer the beta-1 selective agents because they have less of an effect systemically throughout the rest of the body. But propranolol is one of our non-selective beta blockers. So, that would be chosen to help reduce the tremors because it has action throughout the rest of the body and not just on the heart. But it still does have actions on the heart, so it's still something that can be used. I don't think that they would be having as good a control of their tremors if we did switch to a beta-1 selective beta blocker, just because we're not, because the receptors those act on are specifically in the heart. I don't believe that they would be having as good a control of their tremors if we did switch to one of those. So in that case, propranolol would be an appropriate one to continue using.
I just don't know that, from an evidence-based practice point of view, it's not actually, propranolol is not indicated. Maybe something we can ask the people from Chicago about. What I have seen is some people have kind of continued a low dose of propranolol and then gone ahead and added in carvedilol. I have seen that. I don't know if that was just, what that was, but the problem, of course, is that it's not evidence-based practice.
Right,
in
it's not a
regards to-
well-studied area.
Yeah, we'd love to say one beta blocker over another is the same, but unfortunately, that's those medications that he had listed are the beta selected that have been
I've seen
studied.
both used as well.
Yeah, that's what I've seen. Have you? You've seen the same thing?
Not often, but
No.
you get triggered by 2 beta blockers when you're verifying an order, and come to find out the low dose propranolol is being used for tremor.
For the tremor
So
and
they'll
then
have
yeah.
All right, so our next class of medications are the ARNIs, or our angiotensin receptor and neprilysin inhibitors. And this is actually a combination medication. The only one that's available right now is Entresto, which I'm sure is the one that you're all familiar with as well. And this is a medication that's kind of what we'd be switching to from our first-line agents. So our ACE inhibitors and ARBs, in our patients who are tolerating those, it's actually recommended to go ahead to switch over to that if they're heart failure stage 2 or stage 3, so they're having they're symptomatic heart failure patients and they're tolerating an ACE or ARB already. It's actually recommended to switch them over to an ARNI. And this has a little bit to do with the mechanism of action of the ARNI. We're getting a little bit more of, we're tackling our heart failure from another point. And I'll kind of go over this really quickly. Where the mechanism of action starts with our ARNIs starts with pro-BNP, which is broken down into our 2 markers for heart failure, NT-proBNP and BNP. And we have neprilysin, which is the enzyme that we're inhibiting with our ARNIs. What neprilysin does is it takes our BNP and it actually breaks it down into inactive metabolites. And so this is going to actually cause, it's going to keep our BNP from exerting its effects for a long period of time. And what sacubitril, which is our neprilysin inhibitor part of our ARNIs, is going to come in and stop neprilysin from breaking down BNP. And so that's going to allow BNP to stick around longer to exert its mechanism of action, which is going to increase our patients' diuresis, increase vasodilation in our patients, and decrease cardiac fibrosis. Now, an important thing to keep in mind with these patients is that BNP is one of our markers for heart failure, like exacerbations. And so if they are on this medication, their BNP is going to be elevated, regardless of whether they're having symptomatic heart failure or not. But our NT-proBNP, which is another marker that we can use, actually is not affected by neprilysin. So NT-proBNP is the marker to be watching in our patients who are on ARNI. Otherwise, they're very similar to our ACE inhibitor and our ARBs. It's important that when we're switching over from an ACE, to let the patient have a washout period of at least 36 hours. So if our patient took their dose of an ACE inhibitor that morning before coming in, we would have them wait to start their ARNI until the afternoon of the next day. That'll give them 36 hours between, and the reason that we do that is just to reduce the risk of angioedema occurring, because they act at different spots in the renin-aldosterone, or renin-angiotensin-aldosterone cycle, and so we would want to minimize the risk of angioedema by not attacking that cycle at two different spots. Then our aldosterone antagonists, so this is going to be spironolactone and eplerenone, are indicated in our reduced ejection fraction patients, in addition to our other first-line agents, as well as, because it has a mortality benefit in those patients. And in our patients who have preserved ejection fraction, it actually has been shown to reduce hospitalizations as well. So it's one of the agents that we can use in our diastolic heart failure patients. The dosing, again, this is another agent class that does have a target dose, so we'll be titrating to there. Has very similar monitoring parameters to our ACE and ARB, looking at potassium, kidney function, blood pressure, etc. It'd be good to counsel specifically male patients about vancomycin with spironolactone, which is something that they can watch out for, and if they do notice it, then we can switch them over to eplerenone, which does not have that side effect. But those are all, otherwise it's very similar to the things we'd be watching for, very similar to our ACE, ARBs, and ARNIs. Then we have our diuretics, which is often our patients' favorite classes, because this is the medication that makes them feel a lot better. So these are our preferred class of drugs that are used to manage heart failure symptoms and help relieve those symptoms of volume overload. Our loop diuretics are our preferred class, so it's going to be things like furosemide, bumetanide, etc. And I have some slides on the next table that have kind of the dosing of these medications. But important things to watch out with both of these classes, both the loop diuretics and the thiazide diuretics, which would be an add-on to our loops, is watching their vitals, one, for their blood pressure, because they're getting rid of all that fluid can cause patients to have a drop in blood pressure. And it's important to watch their BMP, watching for electrolyte wasting, especially potassium with our loop diuretics. So this is just a table for your reference that has what the initial dose is of our different diuretics and what the maximum recommended dose for these. I know some of these are pretty ridiculously high, like Lasix being up to 600 milligrams in a day. I've never seen a patient ever require doses that high, and usually we'd be switching to another agent or adding on one of our thiazide-like diuretics before we'd be getting that high with Lasix. An important note with these is that this is a class of medications, both thiazides and loop diuretics, that we do not have a target dose for these medications. It's not like our beta blockers and ARBs that we are trying to get to a target dose to see some benefit for these patients. The diuretics don't have these longitudinal mortality or hospitalization benefits. What they do for our patients is they help to relieve their symptoms of heart failure. And so obviously we want to make our patients feel better. We don't want them to be suffering with volume overload, but they don't provide a benefit with regards to mortality or hospitalizations. So we don't have any kind of a target dose. We just would use we would titrate to whatever dose relieves their symptoms of heart failure. I have a little bit of notes about using IV doses of our loop diuretics for management of heart failure symptoms acutely. And basically the way you calculate that is recommended to give you're basically doubling their exposure of what they get with their oral dose. With Lasix, this works out really nicely because you just add up the amount of medication that they're getting in a single day with their Lasix. So if they're taking 40 milligrams twice a day, for example, that'd be 80 milligrams. And then that's the dose we would give IV because of the way the math works out. And I have the equation down there, and as well as the bioavailabilities over to the right that would help you to calculate what an IV dose, or a good starting point for your IV dose would be to try and relieve acute heart failure symptoms. But with Lasix is one that just works out very nicely because it's just the way the numbers work out. It's very easy to kind of figure what your IV dose is going to be. Okay, now we're getting into some of our little adjunctive agents. Abrapidine or Corlinor is going to be one of the medications that we're going to use in our patients who have symptomatic heart failure with reduced ejection fraction to get their heart rate under control. So our goal heart rate for these patients is to get their heart rate below 7 beats per minute. And this is going to be for our patients who, one, are in normal sinus rhythm, so this isn't for our AFib patients or any of our other arrhythmias. And the patients have to already be on a maximally tolerated dose of the beta blocker, because our beta blocker are the preferred agent for heart rate control in heart failure patients. And so this would be like for our patients who we've got them as high as they can go on their beta blocker and their blood pressure just will not take any more of it. And so we can add on Corlinor to their regimen to help reduce that heart rate a little bit further. A nice thing about Corlinor is that it does allow for further titration of other medications by slightly increasing the patient's blood pressure. So when you start a rapid patients, it will modestly elevate their blood pressure. And this can allow for us to increase their dose a little bit closer to the target in our angiotensin receptor blockers, our ACEs, our beta blockers, just to get a little bit more benefit out of those medications. It is important to counsel patients that this is an expensive medication, that you don't want the finances to be something that's going to shock your patients. There are copay assistance programs that are available through the manufacturer, but making sure that the patient's qualified for those is going to be something that's important to do. It's also important to let patients know about symptoms of atrial fibrillation, letting them know to watch out for palpitations, just because of gravity can put people at increased risk of developing arrhythmias. And it's also a good idea to let them know about which are just these harmless visual disturbances that are basically like bright flashing lights and that would be in their vision. These are harmless, but it could be something that's kind of scary for patients to have happen. So it's a good idea to give them a heads up about that so that they're not freaked out if that does occur.
And Dakota, just to clarify on that one, that kind of place in therapy, it's not necessarily a mortality benefiting agent, where this is mainly added on when we're thinking of reducing hospitalizations.
Yes.
Is that correct? Okay.
Yes, that's correct.
What about in patients with just like post-op paroxysmal atrial fibrillation? Can you use that? Or?
So post-operatively, ideally we're going to be controlling their atrial fibrillation with a beta blocker.
No, I mean in patients with a history of paroxysmal AFib that aren't in AFib now, can you use
Like
But
just
they were
after cabbage.
And they were previously in atrial fibrillation.
like so a lot of times after cabbages patients will have it or something like that
But then they'll come out of it and they don't.
within a few days. Yeah.
That wouldn't be a case where I would start using Corlinor in those patients specifically. Tiffany, I don't know if you've seen.
I can't speak to it for the studies, but I don't know that, if this is something that a provider would find that the benefit would outweigh, I can't say that would be an absolute contraindication. If they're in normal sinus rhythm at the time and it's a very, rare occasion that was happening for them, I wouldn't say absolutely not. But then again, the benefit of this right now at this time in the studies that we have in the United States is just a reduction in hospitalizations. So you'd have to really weigh out the benefit. Do you want to reduce the hospitalizations? Is that a better, route for this patient versus the risk of AFib? So
Sure.
Does it increase their potential for having AFib?
yes.
Yes,
It does.
yes, it does.
So,
Oh, you're okay.
Do you use this drug a lot?
I forget about it.
I've never.
I've tried. It's very difficult to get covered, and it's way too expensive for anybody. I tried to get it on someone.
Sample would use
Yeah.
it.
When I worked with Dr. Stample, he kind of used it when he thought that a patient's blood pressure could elevate slightly enough so that he could, increase or add on those mortality benefiting guideline therapy recommended therapy. So that's kind of where he would really utilize it.
Yeah,
from my observation.
And that's a big part of the gravity is that it lets us add on additional dosing of our drugs that do give the mortality benefit. So that's a really big part of the benefit of using it when we can.
And the other thing that
Could they use metronome? Or no?
I don't know what the effect that would have, especially in a HFrEF patient. I'm not sure. But I think the other thing, when Stemple used to do it, he would give them the 30-day card and then he would discharge them from heart failure clinic and then send them over. And by that time, you're off the medication. So, it was really kind of hard to kind of see. But in some patients that they were able to get it patients qualified, I did see that, heart rate definitely came down. You've got that tachycardic patient and you've maxed your beta blocker and their pressure is about 90 to 100. It definitely did seem to work, but.
I have a few on it, and I've
Do you?
got good coverage.
Yeah,
Even
have
from Medicaid, things like that.
Medicaid?
Yeah.
Are you? Woo!
Yeah.
I have a letter, anybody needs it.
You got a good letter?
You
Okay.
got a prior author, and I have a letter that I typed up from sample that got me pretty good coverage. But this was a guy that was tachycardic since he was 18, and now he has heart failure, and he just can't tolerate it. And that's the only thing that really helps him.
All right, coming back to our next agent, and this is a combination of two different agents actually that we would be using together in patients. Our isosorbate dinitrate and hydralazine. So this is indicated in our African American patients with class 3 to 4 heart failure with reduced ejection fraction, as an addition to our ACEs and beta blockers, just in addition to those first line therapies, or in any patient who cannot tolerate those first line therapies. So our patients who have they have poor kidney function and can't tolerate an ACE and ARB, or they have like allergies to the different medications, and this would be these would be agents that we can add on to those patients to get additional benefit. I have just the dosing there. This is of the combination tablet that contains both isosorbate dinitrate and hydralazine together, where we would be initiating. And again, this is one that you will be titrating to a target dose. Biggest thing with these medications, they don't have a huge impact on laboratory values, but they do. You just have to be keeping a close eyeball on their vitals because both of these medications can have a pretty significant impact on blood pressure. And that's something that would be a good idea to let your patient see if your patients are able to do that at home. So seeing if they can get a hold of like an automatic blood pressure cuff for home use would be a good idea with this medication. All right, and then one of my favorite ones is digoxin. And this is our last kind of standard of care medication that I'm going to talk about today. It's another adjunctive agent that we can add on in patients who are on optimized, maximally tolerated therapy with their ACE or ARB or ARNI, and they're on their maximally tolerated beta blocker, and they're still getting symptomatic heart failure with reduced ejection fraction. Then we can add on digoxin to help get a little bit better, to try and help to rein in that symptomatic heart failure. This is a drug that has a lot of monitoring associated with it. We're going to be watching out their vitals, their BMP, looking at their electrolytes, especially with potassium and magnesium, and their digoxin level. And the reason why we do this is because this is a drug that has a pretty narrow therapeutic index, meaning patients who do end up getting too high of a serum concentration, which can happen even at recommended doses, can start developing toxicities to digoxin. And so ideally, we'd be measuring a digoxin level as well after they've been on a maintenance therapy for a little while, getting level 6 to 8 hours after their last dose to hopefully have that fall between 5 and 9. And that's going to kind of guide how we'll adjust their doses, either increasing their dose or decreasing their dose. And the reason why it's so important to watch electrolytes is because specifically abnormalities in potassium and magnesium can precipitate the toxic effects of digoxin. So it can make it more likely that they start having those toxic effects or make it worse. So it's important that we correct any abnormalities in those two labs if we do discover them. It's also a drug that has a lot of drug-drug interactions. So if you're going to start this on any patient, running an interaction screening is going to be something that's very important to do. It's going to interact with a lot of our drugs that either induce or inhibit the metabolism of other drugs. So our azole antifungals come to mind as a big notorious class for doing that, but there's a lot of others. So it's a good idea to always just run an interaction screening on any patient who starts on one of these meds. And then counseling patients about their symptoms of toxicity. So again, this is another medication that causes visual disturbances. And that's actually why I have the picture of Starry Night down there in the corner. It's actually been described as having these halos of lights around the source of light. And so if you look at kind of the stars and the moon and Starry Night, that's very similar to what someone who is having a toxicity to digoxin would be seeing. And now, these visual disturbances, unlike those phosphines with ibravitine, these are a reason to be concerned because it's a sign that they have toxic levels of digoxin, and that would be a reason for them to come in. So it's something that can be a confusing point, but I don't want you guys to be confused between the harmless phosphines that we get with abravitine versus these visual disturbances with digoxin, which are much more serious. Okay, and so just to kind of summarize where we came from with our diagnosis of heart failure with reduced ejection fraction that is symptomatic, so our stage C patients, we're going to start an ACE inhibitor, ARB, or an ARNI, get them onto a beta blocker, and then titrate those drugs to their tolerated doses to get the most benefit out of them, or to their target dose if we're able to get there. And then we'll start adding on our other agents as they're indicated, so adding on our loop diuretics or thiazides to help get control of our fluid overload symptoms, adding on our aldosterone antagonist to our patients who are still having symptoms after being started on our beta blocker and ACE and ARB to get more benefit for them, considering digoxin in those patients who are on optimized therapy but still having symptoms, adding on abravitine where we talked about before, and then adding on hydralazine isosorbide dinitrate in addition to first-line therapy in our African American populations, or in addition, or in replacement of our beta blocker ACE ARB for our patients who can't tolerate those.
And Dakota, I do want to point out a couple things on this slide, some minor corrections. With the ivabradine, it's NYHA class 2 to 3, and the isosorbide dinitrate combination is a class of 3 to 4.
Do you have to use the dinitrate?
Supposed to, right?
Ideally there would be
to
used in
see
combination.
the same mortality benefit that was seen in the studies, then yes.
Okay.
If you're just using it, if you're using it not in an African American patient, but in any other patient,
Okay.
just for symptom control, then I don't see why you couldn't use a different agent.
And you said that was 3 to 4?
Yes,
Yes.
per the 2017 update.
Hey, before we move back into SGLT-2 inhibitors, is going back to your slide about like some of the side effects of this, is amputation still a worry? That was maybe a worry, maybe not.
Yeah, so that's something that you kind of have to wonder about the studies that Warren came from, where they were seeing it. So our SGLT-2 inhibitors are getting added on to our patients who aren't seeing control of their A1C and their blood sugar with just metformin and lifestyle modifications alone. So these are patients who may not have the best control over their diabetes already. They may already be at risk of having an amputation already just from the fact that they have a blood sugar that's a little bit more hard to control. So it's not something that I put a whole lot of stock in that they truly do increase the risk of amputation. I think the data behind that is a little bit shaky. So it's something that I kind of take with a grain of salt. It's entirely possible that there could be a real association there, but I don't think that we have the data that really proves that that is true.
Okay.
All right, and so now we'll talk a little bit about the evidence behind what made us start to consider SGLT-2 inhibitors as an add-on for our patients who have heart failure. And so we'll be talking a little bit more about the EMPA-REG trial, the CANVAS and CANVAS-R trials, and the DECLARE-TIMI 58 trial, and then we'll briefly touch on some other published and upcoming literature. Now, the EMPA-REG trial is our study for empagliflozin, which is one of our SGLT-2 inhibitors, and this is the first one that kind of came out. To give a little bit of background about what these studies are, for all of our antidiabetic or oral antidiabetic medications, because we saw an increased risk of cardiac events in some other classes, we started studying each and every single one of these oral antidiabetics with regards to cardiac outcomes to make sure that we're not missing an increased risk of like CV death, stroke, MI, etc. with these other agents. And so the empagliflozin study here, EMPA-REG, was the first one to come out, and this was in adult patients with type 2 diabetes with a BMI of 45 or less and a creatinine clearance of 30 or greater. So again, coming back to those cutoffs with our renal function, it's an area that we're not studying below this 30 mils per minute cutoff. And all of these patients, something very important to know about the EMPA-REG study is that all of these patients had established cardiovascular disease. So they had some kind of coronary artery disease, or they had some kind of or peripheral artery disease, or something that was already there and present. In addition, these patients had an A1C of 7%, 10% didn't have any kind of glucose-lowering agents in the 12 weeks prior, or any changes to that in the 12 weeks prior to starting the study. And so they ended up including 7,000 or over 7,000 patients in their final analysis. They studied 3 different arms of empagliflozin, giving either 25 milligrams, 10 milligrams, or placebo. And they stratified them by a few different of the confounders they identified. And they were giving this SGLT-2 inhibitor in addition to standard of care medications. So if our patients had a diagnosis of heart failure with reduced ejection fraction, then they would be getting the standard of care medications at that time. And that's kind of why I wanted to set the stage for this. So any other indications they had, they would be getting in addition to their SGLT-2 inhibitor. And so when we got the results back from the study, we had a pretty pleasant surprise. All of these numbers that are in red here on the slide are results that are statistically significant. And so when they pooled together the results of the high and low dose of the empagliflozin, they didn't see a real difference or a big difference between the two. And so this is comparing the hazard ratio of our patients who got placebo versus got the drug at all. And so with regards to MACE, which is a composite outcome of looking at patients who either had MI, they had cardiovascular death, or they had a stroke, we had a hazard ratio of 0.86%, so about a 14% relative risk reduction in our rate of having one of these MACE events. And that's one of our events that reached statistical significance. Similarly, down the line, we had a significant difference in all-cause mortality, CV death, heart failure hospitalizations, and then the composite of CV death and hospitalizations. And so we saw that these results, and we were like, wow, we're seeing a lot of benefit with our SGLT-2 inhibitors in our patients who already have active ASCVD going on. And so kind of what the takeaways from this is that, we're seeing a lot of these cardiac benefits in this drug. This wasn't something that was expected. We were doing these studies to see if there was any risk of worsening their cardiac outcomes, and we found benefits. A good thing to note about the study is that it did have a mean follow-up of about 3.1 years. So these are effects that we're seeing very quickly after the initiation of these medications. It's not something that we're having to wait like decades and decades to see the benefits. We're seeing this effect after about 3 years on average. And so in our patients who have ASCVD, after having this study, we're like, wow, starting an SGLT-2 inhibitors might not be a bad idea to see these benefits. Additionally, we also saw lower incidences of AKI, and a higher incidence of congenital urinary infections, which is something that's been demonstrated with these classes kind of over and over again. They're just added considerations with these medications. Now, a little bit later, we had the CANVAS trials. So CANVAS and CANVAS-R, which was looking at canagliflozin. This broadened our patient population that we were looking into. So it included our patients who were at least 30, had type 2 diabetes, and had one of our ASCVD diseases, so peripheral artery disease, coronary artery disease, already established. But they also included our patients who were a little bit older, 50 years old or older, had type 2 diabetes, and they had just risk factors for ASCVD. So they didn't have a diagnosis of ASCVD or atherosclerotic cardiovascular disease like coronary artery disease or peripheral artery disease, but they had multiple risk factors for developing one of those diseases. Again, they set their cutoff for kidney function at a GFR of 30. They excluded patients who had a very recent ASCVD event, so recently had a stroke or recently had an MI. And they ended up including a total of 9,734 patients. This was another 3-arm trial where they did 2 doses of canagliflozin against placebo, and they gave the study medications again in addition to the standard of care medications that would have been given to the patient otherwise. And so this is how the study ended up resulting out. So still fairly impressive. We did see a reduction in MACE. We didn't see the same reduction in all-cause mortality or CV death that we had before. And then we did see a good reduction in heart failure hospitalizations as well. So all these numbers in red are statistically significant. The ones in white, we didn't reach statistical significance. So if we were to repeat the study, we might not see these same results, and we might actually see no benefit with this drug in those 2 endpoints. But all the ones in red, we would expect to see benefits with repeated studies. And so we did see a repeat of reduction in heart failure hospitalizations at MACE events again. And this included our patients with ASCVD risk factors. So what I want you to keep in mind is that as we start adding in more and more patients with our ASCVD risk factors, what we start to see is that we have less of a benefit with our CV death and mortality benefits. But something that remains constant is this heart failure hospitalization is still sticking around. This study was similar with our EMPA-REG trial with regards to median follow-up. Again, we're seeing these effects very quickly after initiating these drugs within a few years. And we had a similar A1C in each group, actually. So it kind of brought into the question the outcome. People were already theorizing after the EMPA-REG trial what the mechanism of these benefits were. And previously it was thought that, it's because we're getting their diabetes under better control, we're reducing their A1C. But we actually saw kind of similar A1Cs, didn't see a major difference between the groups that were having benefit. So this brought up some questions kind of about the mechanisms of which our SGLT-2 inhibitors were really providing a benefit for our patients, and that maybe it wasn't just the glucose-lowering effect that they had. Another important thing to note is that they did do a subgroup analysis, although the study was not powered to look at every subgroup and say for certain that they're preventing any kind of statistical errors with those. But there are some interesting trends in the subgroup analysis where in our patients who did have established ASCVD, and they looked at just those patients alone, we were reaching statistical significance in some of those primary outcomes like MACE, or like our cardiac death, versus in our patients where we look at just our patients who have multiple risk factors alone, we don't see that kind of benefit in death, but we still see the benefit in hospitalizations. So it's another thing to kind of clue you into what's happening with the data there. Then our last trial, or our latest trial, is the Declare-TIMI 58 trial. Is another very similar in setup. What is important about the Declare-TIMI is that it included a very large population of patients with just ASCVD risk factors and not established ASCVD. So over 10,000 patients. So more than half of the study population was just risk factor patients and not clinically established ASCVD. The inclusion criteria were very similar. Patients had to be 40 or older and have type 2 diabetes. Just like the other studies, every patient had to have type 2 diabetes to be included. And this was just a 2-arm trial, so they just compared a 10 milligram dose versus placebo, given in addition to standard of care again. And what's cool about this is that we add in all of these patients who have just risk factors for ASCVD, and we're still seeing this significant benefit in heart failure hospitalization. We also saw a benefit in the composite of CV death and heart failure hospitalization, although it's pretty obvious when you break it down that our heart failure hospitalization is the significant component of that, where CV death alone didn't really reach the statistical significance. And so what we can really take away from this is that, yes, we don't see as great of benefits in our patients who don't have ASCVD and just have risk factors, but we are still seeing a heart failure hospitalization reduction regardless in both groups, those who have ASCVD and those who just have risk factors. Again, this study is another one that did a subgroup analysis looking at our patients who had multiple risk factors and those who had established disease. And we were seeing stronger trends towards statistical significance. They didn't actually reach significance, but again, they weren't powered to actually prevent any kind of errors with statistics there. But we were seeing much stronger trends towards having these significant reductions in MACE and CV death in our patients who had ASCVD already established. And I think that just kind of supports the pattern that we've been seeing with these SGLT-2 inhibitors and which patient populations are seeing what benefit with these drugs. And so just to touch on some of the other observational studies we've looked at, these aren't as strong of data as our randomized controlled trials like EMPA-REG, Declare, and Canvas were. But these are just some other observational studies where we've been kind of seeing the same trends pop up again and again with these SGLT-2 inhibitors, where we've been seeing these reductions in these cardiovascular events. So it just kind of adds to our pool of evidence saying that, yes, we are, although it's not as strong evidence as our randomized controlled trials, we're repeating studies with other methodologies and finding the same kind of results again and again. Now, some upcoming literature that I'd like you all to keep an ear to the ground on are the Virtus CV trial, which is going to be the same kind of setup as our previous 3, but will be with our 4th SGLT-2 inhibitor, ertugliflozin. They're estimating to have around 8,000 patients, and they will be completing sometime in September 2019 is their estimated date. There's a lot more information. I've included the ID number for clinicaltrials.gov that kind of breaks down a lot more of what they're doing with the study. So if it's something that you're interested in finding more about, I recommend going onto their website and searching this ID number on there, and they'll be able to provide you with a lot more information about the study there. Another upcoming trial that I think is very interesting, especially for our heart failure patients, is the DAPA-HF trial, which is going to specifically be looking at cardiovascular benefits in our patients with reduced ejection fraction heart failure. And so this is going to be a big confirmatory study for us about benefits in our patients for heart failure. And it's going to kind of I'm hoping that it's going to confirm the benefits that we've been seeing with these bigger trials when we're specifically looking at heart failure patients. This one's set to come out around 2019. Again, I've included the ID number here on the slide, so please, if it's something that you're interested in, go and take a look for it on that website. And so, kind of to summarize the bottom line of the lecture is that we have a heart failure hospitalization that across all groups that we're studying with these drugs, whether they have multiple risk factors for ASCVD or they have a diagnosis of active ASCVD, we are seeing a heart failure hospitalization benefit in those patients. Moreover, in our patients who have established ASCVD, so our patients who have like coronary artery disease, for example, we are seeing a mortality benefit as well. Now, we're still waiting on a couple more trials that hopefully will continue to show us this repeated pattern and add to our pool of evidence that SGLT-2 inhibitors do have benefits in our heart failure patients at reducing CV events and at reducing heart failure hospitalizations. But I think with the evidence we have right now that we have a very logical niche for patients who have type 2 diabetes and heart failure to be recommended to be started on one of these medications. A nice thing to keep in mind is that heart failure is one of the risk factors for ASCVD that they were looking at in these studies. So heart failure in and of itself isn't an atherosclerotic cardiovascular disease. It doesn't. Its primary mechanism isn't through ischemia, although that is often the case for a lot of our heart failure patients, is that they have heart failure secondary to coronary artery disease, but they're not able to perfuse that heart well enough. But it's not all of our heart failure patients. But no matter what, if our patient has a diagnosis of heart failure, they're already at risk of having ASCVD. So it therefore follows that these patients should see a hospitalization benefit because they have these multiple risk factors for ASCVD. They have the heart failure, they have diabetes, which is a risk factor as well. So both of those should, because they both have both of those, they should be seeing a hospitalization benefit, if nothing else. And then moreover, if our patients have like coronary artery disease already diagnosed, then yeah, these patients definitely, we want to be recommending it because we were seeing this mortality benefit in the studies and they have established ASCVD and diabetes. So yes, definitely we would want to be starting it in those patients. It's very important to keep in mind the warnings with SGLT-2 inhibitors. So the things that are going to stop us from recommending this drug are going to be our patients who have those frequent UTIs or have the risk factors for very severe UTIs, so like our truckers or frequent recurrence of UTIs or urosepsis, or if they've been hospitalized for that in the past, it might be something that we're using. Or our patients who have like the osteoporosis and are at increased risk of bone fractures in those patients. So you have to keep those warnings in mind whenever you're thinking about starting one of these agents or recommending that they be started on one of these agents. But we see a lot of very good benefits with it as well. So it's one of these cases where we have to weigh the risks of starting this with the benefits that we'll see. Another interesting point that I'd like to bring up with this medication is that it also does have a diuretic effect. So I think, in theory, we could be seeing more relief of our fluid overload symptoms because it does cause diuresis on its own. This isn't something that's been studied for heart failure, so this is just my speculation. But it's another thing to keep in mind, too, is that we're going to have another mechanism of diuretic effect. So this could be something that helps out our other diuretics with relieving the patient's fluid overload symptoms. And then finally, I do want to reiterate that the 2019 update to the ADA guidelines on type 2 diabetes do actually make a specific recommendation for SGLT-2 inhibitors now for patients where heart failure is a big concern and a big focus, as the first agent that you would add to metformin. Because for those who aren't super familiar with diabetes, metformin is our first oral agent that we'll add on, and then we have a whole slew of second oral agents that we can pick from to add on to metformin. And so the diabetes guidelines today have made the recommendations that yes, SGLT-2 inhibitors are going to be our preferred add-on agent in our patients with either ASCVD along with our GLP-1s, or specifically in heart failure, they are the preferred agent. So where they kind of fit into our heart failure with reduced ejection fraction table is kind of as a little add-on with it's another agent that could be indicated in our patients that we would be considering adding on when they have the indications. So primarily when we have comorbid diabetes going on, it's going to be a preferred agent to control their blood sugar. And so this is kind of just a final breakdown of the recommendations. To strongly consider it in a patient who has type 2 diabetes and any ASCVD diagnosis. It's fair to consider its use in any patient who has type 2 diabetes and heart failure because they're both ASCVD risk factors. And then we'd be avoiding it or reconsidering its use in patients who have who are more concerned about the side effects with SGLT-2 inhibitors in.
Okay, before you go into the questions,
Yeah.
I'm going to try to finish this on the Kahoot thing because the people online will have to participate. So let's take some questions first, and then we'll do the actual quiz.
Certainly, yes.
So if, all of our diabetic patients are at risk for increased urinary tract infections, just the diabetic disease process period, is there a way that we could proactively treat or help them through dietary measures, changing the pH of the urine to decrease their risk?
As far as changing the pH of the urine, I can't really speak to that, and that's a limited area of knowledge of mine. But I don't know that I've ever seen a patient who was specifically on a therapy to increase or decrease pH.
It's a lot of like the cranberry tablet, doing the cranberry tablets, pushing the cranberry juice, pushing the fluids, avoiding the sodas, those types of things. We do that with our urinary, like in my continence world. We look at bladder irritants or things to increase or decrease pHs. So I was just wondering if that was something that you could proactively discuss with them.
So I think definitely the lifestyle modifications, avoiding the soda, avoiding the sugary drinks, that's going to be putting a lot more sugar for them to get rid of into their bloodstream, definitely. And that's going to go right in line with their dietary modifications for diabetes as well. Now, the important thing to keep with the cranberries or cranberry juice, it's a good thought, and it does have some support to prevent UTIs. The important thing to keep in mind is that it does have interactions with different medications as well. So it can, specifically our drugs, where we're worried about drug metabolism interaction, selective dioxin is a good example, where we would be worried about those interactions kind of interfering with the drugs that they're on. But if it's something that they're not on a lot of drugs that interact with it, then I would not see the harm in recommending them to use that as well.
So if you have a patient on metformin and glucoside, and they have heart failure and CAD, we want to put them on, Jardiance or Invocana, would you stop the glucoside, add the starting dose, or would you add it to the two?
That's a very good question. So it can be added on as you can have more than 2 agents for diabetes for sure. So it could be an add-on therapy. I think where you're going to find that answer is how well controlled is their A1C. If their A1C is already well below goal, then you probably don't need to have 3 agents on board to help reduce that. And that would be a case where I would say, yeah, go ahead and switch out the glucoside with the SGLT-2 inhibitor and see how they do with that regimen for a while. And you're not going to see the impact of that for probably 3 months down the line, just because of how long it takes for the changes in A1C to kind of present themselves. But on the other hand, in your patients who maybe are not quite at goal or just are barely making goal, then adding on the SGLT-2 inhibitor to their current therapies would probably be the way to go. And the nice thing about the SGLT-2 inhibitors is that they're another medication that have an initial dose and a target dose, where we'd be titrating up, but that's because we see a greater benefit in reduction of blood glucose. If you'll remember from the different studies, they were seeing very similar benefits in the CV outcomes regardless of the dose they got, whether it was the low initial dose or the high target dose for these drugs. So it's something that, maybe we just stick on a low dose of the SGLT-2 inhibitor, and then they're getting their cardiac benefit, and they already have their blood glucose benefit. So
Also, Dakota, I think that, I personally probably would rather switch them out as well, just based on their increased risk of hypoglycemia and based on the mechanism of action of glipizide.
Right.
So I would prefer to switch, just on my experience.
So I've been going to a lot of talks on this particularly because I'm trying to work up the courage to actually order one of these SGLT-2 inhibitors. So one of the talks I went to was endocrinology and cardiology together, and this endocrinologist said after a year he takes people off glipizide anyway because it just seems to stop working after a year. Have you heard that? I mean, is there any validity to that?
I cannot speak to that. It would be something I would have to look up.
The mechanism of action of glipizide is basically inducing the insulin production. So if it's a patient who has on type 2 diabetes for a long time, your insulin production is already compromised. So after 1 year, that insulin production could decrease just because you're squeezing the pancreas at its best. So that might be one effect that you see add on for a year, and then they see this is it. This is the best effect you can get. So
okay.
Dakota, I'm going to kind of switch gears on the question just for a minute, but we focused a lot on where it fits in reduced ejection fraction. Can you speak your opinion on potentially using this in preserved ejection fraction?
Yeah. So either way with heart failure, whether it's reduced ejection fraction or preserved ejection fraction, both are counted as risk factors for ASCVD. So again, this would be, it's kind of second verse, same as the first. You're going to see the heart failure hospitalization benefit, whether you're using it in a patient who has reduced ejection fraction or has preserved ejection fraction. And I mean, the primary thing that's driving whether they're seeing a mortality benefit or not is whether or not they have established ASCVD. So both your patients with reduced and preserved ejection fractions will see those kinds of benefits. So yes, you can use it in both, and I would recommend it for both.
Yeah, and I think that, when I specifically picked apart the studies, they don't really differentiate between preserved or reduced ejection fraction in the studies. So I think that the new study with the dapagliflozin specifically looking at reduced ejection fractions will really just pick those specific patients out, and we'll see if it falls in line with everything that we have seen thus far.
That is true. So we don't have a lot of the studies. We don't have a lot of data regarding specifically preserved ejection fraction. So my comments are extrapolations based on the fact that they are established as risk factors for ASCVD and based on the inclusion criteria of these studies where we're seeing the benefits. However, that's where my recommendation is coming from. But It will be interesting, yes, to see. So like the DAPA-HF trial is looking specifically at reduced ejection fraction, seeing what benefits we see specifically in that population. And then hopefully down the line, I imagine we'll eventually be looking at preserved ejection fraction patients as well, although I'm not aware of any study that's currently underway.
But there's no difference in coverage for preserved versus reduced?
As far as insurance goes? That's a good question.
Well, because you're probably giving it for diabetes. And
exactly right. So they have the primary indication for that drug anyway.
Do they have to fail? Like, let's say they're on the glipizide and the metformin, and I just want to stop the glipizide, and do I have to prove a failure with the hemoglobin A1C with the glipizide, or how do I do that?
I would think that each company is going to be specific. I can't really speak to that, but now with current guidelines, if they are reevaluating, I think that you have a valid argument to say my patient has heart failure. Look at the 2019 ADA guidelines.
Yes.
This is not working for my patient, and it's not necessarily the first line agent for them either, it's appropriate to switch.
Yeah.
So
your biggest piece of ammo there is going to be those ADA, that 2019 guideline to ADA. I can, they have a very nice table there that kind of breaks down what the recommendations for the SGL, or for the oral agents for diabetes are. And they make it very clear that SGLT2 is preferred for patients who have heart failure, so that's going to be a very big piece of ammunition for you.
Okay. Are any of our heart failure or outpatient people at all prescribing this, or are we just recommending it?
Nalamathu and Gillar.
They are actually prescribing it.
Yep.
And then are they sending it back to the primary to monitor any effects on the glucose, or how's that? I'm hospital based, so I'm not.
I'm not sure how they're doing it, but I've seen
They're doing it.
I've seen Gil do it multiple times.
Okay. Just wondering, because it's kind of cross.
what I have seen inpatient really is that, many times, I can't speak for everyone, but sometimes they'll stop some of the oral agents and then just do sliding scale insulin while they're inpatient. So I don't know, and I don't know even which ones of these we have on formulary, if any. I didn't even look at that. So if they came in, they potentially would have to use their own supply anyway in the hospital setting. So I think the majority of the time you'll see it in the outpatient setting.
I can tell you last year at ACC, I asked Dr. Shelton, are we going to start, prescribing these? He said, I don't know that I want to get into that.
That's my question.
He's like, I don't even want to manage INRs.
It's not going to affect me primarily, but just curious about our.
So I did start an SGLT2 inhibitor on one patient in Rushville, but I did it in conjunction with Dr. Schroeder. I literally picked up the phone and said, "Hey, this is what I want to do.
Well,
is this okay with you?"
Yeah, and that makes perfect sense.
And then she's like, "Hey, I'll do it." And I was like, "Oh, good."
I do think one thing to keep in mind here too is that the renal cutoffs are pretty high that they studied it in. So I kind of see these more in younger patients. So like maybe 50 to 60 up to 70 maybe, with still potentially okay renal function. Because as we get older, they're more volume depleted. They're more sensitive to agents acting in the kidney. We've actually had I spoke to the ICU pharmacist, and he can speak to at least one, maybe two patients he has seen come in with euglycemic ketoacidosis on these agents. So I think that you'll really have to pull the whole picture of the patient. But hopefully, if they are at that lower age, maybe they have commercial insurance still, not Medicare, and maybe the copay, maybe there are copay cards out there and things like that for them, so that it would be a reasonable price.
The euglycemic ketoacidosis, tell me the symptoms of that. Like, what does that look like?
Yeah, their blood sugars are not going to be the first thing that would be alarming. I would assume
stomach pain.
Yeah. I think shortness of breath as well.
Right, and so the main thing you're going to be looking at to diagnose that is going to be their anion gap as well. That's going to be the main piece of evidence from a laboratory standpoint that you'd be using that would alarm you. So
unless you draw blood gas.
And yes, blood gases as well.
Well, what's the etiology behind the ketoacidosis when you said euglycemic? Why?
That's a really great question. It's not something that I'm terribly familiar with.
I honestly would have to look more into it to explain it. I'm not sure if it's just a finding that they are seeing, it's just like a correlation, or if there is a kind of mechanism behind it. I would have to look into that more.
Up to date.
Any other questions?
I will point out two things on here. So back to the aldosterone antagonists, we have a cutoff in here, serum creatinine 2.5. It's typically 2 for women, 2.5 for men. And to answer the question about that losartan 150, yes, it is in fact it's an off-label use, but that is it's in Lexicomp, it's in different literature. It's just an off-label use.
Can I I ask a question to that? And since it is off-label, do you know if you get much more blood pressure lowering effect after 100, or if it's more effect on heart failure? Because we've seen these, on a slightly different topic, we're seeing these, kind of resistant hypertensive people, and you have them on 100 low sartan, and then you're having to do an additive agent.
Mm-hmm.
And I'm wondering if there's any benefit in taking those people up to 150, or does it kind of have a, like amlodipine would have a ceiling effect at 10. I mean, does it have kind of a ceiling effect on the hypertension? Because it lists 100 as the top guideline for hypertension.
My assumption is that those patients were just on that dose and they ended up seeing more mortality benefit from that. I don't know that I can speak to the upper limit of actual blood pressure.
I'd be curious to see if there's been a study around looking at those two doses.
I'm sure that when they capped the dose for heart or for hypertension, they were seeing less benefit, more side effect is probably where that recommendation came from. But I think that the 150 was based on a mortality benefit that they were looking at.
Anything else? Okay, so if you log into any browser on your phone and type in kahoot.it, not .com, kahoot.it.
Is this for nursing credit?
Yeah.
I don't care. I got consult. But I did the test if anyone wants it.
And then enter the number 558298.
Thank you. That was great.
Thank you.
It's a great overview.
And
Sure.
Hey,
Glad I
can
got
I
to
use some
come.
of your slides?
Yeah, of course, you're welcome to.
Will you email them to me?
Can you
Yeah, I can do that. If you-
she made and then email it to me and I'll email it out to everybody.
Yeah. I'll go ahead and do that. We'll just make a couple of clarifications on the slides.
Okay.
We'll get it to you.
Hey, can I ask one more thing? And this seems like a no-brainer, but on your canvas, and can you actually write out what drug they're studying? Because you.
Oh yeah, I apologize for that. Yeah,
That's
I'll
okay.
make
I
sure
mean, logically we can figure it out, but I share some of these with my partner.
Yeah, I'll keep it on. I'll make those updates.
No, I don't know.
That way we can.
It's funny, primaries aren't really comfortable with these drugs either.